Hello, everyone. I'm Charles Thompson. I'm with Cardiovascular Institute of the South in Zachary, Louisiana. I want to thank Dr. Walker and the NCVH staff for inviting me to present some information. I'll be talking today about long-term monitoring in the evaluation of syncope and occult atrial fibrillation. So these are my disclosures. I have several personal disclosures. I have a rather practical one that I keep very close at heart. So to start off with, let's actually talk about what we want to go looking for. You have to understand your game, your quarry, before you can actually figure out how to go hunt for it. So what exactly is syncope? So syncope is very specific. It's the transient and self-limited loss of consciousness. But it's not just that. It has to be due to global hypoperfusion of the brain from any cause. Now, some people call it passing out, fainting, blanking out, falling out. People have a lot of different terms for it. But you have to understand it's the global hypoperfusion of the brain. So what are some cardiac causes? I like to divide it into cardiac and non-cardiac. So typical cardiac causes are bradycardia, tachycardia, SVT, VT, including all the long QT, Brugada, ischemic causes of VT, neurally mediated cardiac causes that produce bradycardia or tachycardia, such as neurocardiogenic, vasovagal, vasodepressor syncopes, and cardiac valve disease. Causes of syncope from a non-cardiac source are things like orthostatic hypotension, carotid sinus hypersensitivity, cough syncope, psychogenic syncope, urination and defecation syncope. This is not syncope, and we have to understand those distinctions as well. So there are things that people get labeled as syncope that are not, and those are pseudo-syncopes, such as seizures, psychiatric disorders that prompt people to do bizarre activity. Vertebral artery stenosis produces drop attacks, and those are from acute limited hypoperfusion of the brain and is not global hypoperfusion. Carotid artery disease and simple falls. So let's talk about atrial fibrillation for a second. It's scattered, irregular, random heartbeat associated with mitral valve disease was the first description of it back in 1749. And it wasn't really well understood until 1906 when it was first electrically recorded back in England. So it comes in multiple modes, and we like to pigeonhole everything in our lives. So atrial fibrillation itself is pigeonholed. Paroxysmal, where it lasts for seconds, minutes, hours, days, and you go in and go out of the rhythm by yourself, and you don't require special medications to get out of atrial fibrillation. Persistent atrial fibrillation is when you require some type of antidysrhythmic medication and possibly electrical cardioversion to restore normal sinus rhythm. And then there's long-standing or permanent atrial fibrillation, where it doesn't really matter what we do, you are always in atrial fibrillation. So how common is atrial fibrillation? It's actually fairly common, especially over 65 years of age. Almost 10% of people over 65 have atrial fibrillation. And the problem with it in this age group is most people don't know about it. Atrial fibrillation has been increasing, especially in patients under the age of 40, where it's actually now a 1 in 4 lifetime risk. So that's increasing to a 25% population over the age of 60. Eventually, we're going to reach that benchmark. So what are the risk factors for atrial fibrillation? Who do you have to look for atrial fibrillation for? Again, patients over the age of 60, diabetes, high blood pressure, previous coronary disease, especially those with myocardial infarction or previous bypass surgery, cardiomyopathy, whether it's associated or not associated with heart failure, pericardial inflammation, viral, other etiologies, thyroid disease, sleep apnea. This is a big undiagnosed player in the production of atrial fibrillation, especially as our society becomes more and more obese, COPD, and alcohol use. So what are we actually trying to accomplish in the evaluation of syncope and atrial fibrillation? We're trying to actually identify the true diagnosis. We want to see the true rhythm. Is it VT? Is it atrial fibrillation? Is it bradycardia? Is it tachycardia of some other etiology? But the other part is that people often forget is we want to exclude the heart as a source of the symptoms. Because again, if it's not the heart, it may be blood pressure, hyperorthostasis, it may be seizure activity, it may be other non-cardiac sources of the syncope. So evaluation. History, history, history. That is ultimately important. You have to get a really good history from the patient because that's often the eye-opening information to tell you which path to go down and what to look for. It's the history of the present illness from the patient, but also from bystanders who witnessed the syncope. Past medical history, cardiac history, family history, and exam's important, but history is where all the meat of the information comes from. But during exam, you can hear a murmur of aortic stenosis, which may be resulting in syncope. You can have other identifying factors such as irregular rhythms, poor pulse, those kind of things from the exam. So what do we want to do? So you have to figure out what testing you want to walk toward. So the exam and the history may prompt you to walk more toward tilt table. Is it more like orthostasis? Are you looking for that? And are we not really looking for true syncope or for true cardiac causes of syncope? Do we want to do an echo? Is there a loud murmur? Do we have symptoms of acute coronary syndrome and should we proceed to cardiac cath? Do you have an EKG that shows short runs of ventricular tachycardia? Should we just proceed to formal EP study? Carotid ultrasound, transcranial, but then you have to listen to the history and start thinking about whether a 24, 48-hour Holter, 30-day or longer monitors, or even a multi-year monitor such as a loop recorder would be appropriate. So let's talk about these 24 and 48-hour monitors. They're very quick to apply. You're very well, patients tolerate them very well. And today they're very small. Formerly, there were these big things that look like cassette replayers. You put a cassette tape in them. Now it's the size of like a money clip or something like that with 3 wires, limited skin irritation, and there's very high compliance with completing a 24 to 48 monitor. The drawback is it only gives you 24 to 48 hours of monitoring. A lead falls off while the patient sleeps, you lose those hours. But all in all, they can get you the information if the symptoms are occurring within every 24-hour block. So sometimes on the Holter monitor, you can identify, this is a recording from someone with a Holter monitor, identified a patient's symptom, and lo and behold, atrial fibrillation. Another time, you can identify long pauses, even though the patient may not have been symptomatic because this may have occurred during sleep. So most of the time, though, 24 and 48 hours, Holters are you're not so lucky, especially if the symptoms occur infrequently. So depends on what study you look at. 2 to 50% of Holters are abnormal. But again, 2% abnormal. Up to 35% have symptoms without any recorded findings. And personally, I kind of think that that's even higher. I think the most common finding of a symptom is a normal EKG. So what are reasons to get a Holter or 24 or 48 hours? If they have known atrial fibrillation, you're getting it to look at their overall ventricular rate control. Do they have presence of bradycardia that you may need to back down on medications? Do they have presence of pauses? So let's talk about 7 and 30-day monitors. They come in all kinds of shapes and sizes, clip on your belt. They have multiple wires, 2 wires, and there are also now monitors that you apply directly to the skin as a little patch and remain there for the entire time. So again, these 30-day monitors, 7-day, weekday, 2-week monitors, they're very quick to apply, but they require some more patient education. They're generally well tolerated because, again, they're very small inside, few wires, very little skin irritation. But your compliance to completion begins to drop off because there's so many days involved with placing the electrodes on the skin, recharging the batteries. You get 3 or more electrodes recorded at each time, and there's large volumes of data to review, which is time consuming for the physician or technicians to go through. Now, the only drawback of these, again, if the symptoms are occurring infrequently, then you may only have 7 to 30 days of information to look at, and the patient may have an event a week later and you never catch it. So most studies suggest that there's an increased efficacy the longer that you record a patient. I mean, that goes without saying, but it's actually been documented. Especially when you're looking for patients that have syncope that is infrequently occurring. So this is kind of what you see. This is just a report from a prolonged monitor. You get the technicians generally go through, record strips that may be of interest, such as non-sustained VT, ventricular pauses, tachycardia. You get a good readout of what their average heart rate is over several days period, and it will give you a better information about, is their atrial fibrillation rate controlled, is it not controlled? You'll also get symptom events recorded to where you can go down, drill into the information and see what was occurring when the patient had a symptom, such as pauses, rapid rates, uncontrolled atrial fibrillation, or other tachycardias. So something that we don't talk about much as a cause of syncope is a cryptogenic stroke. Now, there's a lot of talk about cryptogenic stroke these days, but it's been linked to undiagnosed atrial fibrillation. So that's why I think it's important we talk about it. If you have someone with a stroke, they have no intracardiac thrombus source, they don't have significant carotid disease, you really, really need to begin to think about atrial fibrillation as an etiology. These patients are much better suited to get an implantable loop recorder because these atrial fibrillation events in those patients can be very sparse and few in between. And if we don't know about them, we're not going to be able to treat them appropriately with anticoagulation that they may need. Loop recorders come in multiple different sizes. They're very small, and they're about as difficult to implant in a patient as anyone getting a pierced ear or something like that. It requires no sedation. You numb up the skin. It's injected. It just takes a few minutes. And the thing about it is the patients really don't have to do anything. All the companies that have these implantable loop recorders available, the bedside monitor automatically records the information every single day when they go to bed at night, looking for the device to record and report to you if you have an event. So it's very well tolerated by the patient, and the patient really doesn't have anything to do. These are the bedside monitors from all the different companies. You simply stick it by the bedside and it works. So here's an important, as a final note, this is an important document that I think anybody that's interested or works with patients in the emergency room or in primary care and sees patients with syncope should really read about. This was an important publication talking about evaluation of syncope in the emergency department. And the important part about this document is it goes through who should be emergently admitted for syncope in the emergency department. It really helps sort those things out for you. It'll help you figure out in the office in front of a patient, wow, this is a patient with high risk, should be admitted or not admitted. And with that, I want to close and thank you for your attention and thank you for your time.
That's all, folks.